5, 4.
Hi, this is Kim Coleman, candidate for Congress in Utah's 4th Congressional District, coming to you again. We're yellow status in the state and through most of Salt Lake County, but we're still not on your doorsteps. We're still not gathering in small quarters. Hopefully that's going to change soon, and I can come meet you face to face. But in the meantime, this is how we're trying to communicate and talk about the issues. So please, if you're watching now or even later, please add your questions and comments in the thread, and we will get back to you as soon as we can. I'd really love to answer your questions. We have a primary right around the corner. I won convention, or was the top vote getter in convention a couple weeks ago. So we're headed into a primary where I've already outplaced the other candidates on the ballot. So I just need to go beat them again. So I need your help. I'm looking for your help, and you can go to kimforutah.com. So tonight, I'm so excited to have someone with me to talk about some real critical issues, and somebody that we kind of connected on healthcare issues. I think we had kids that played on the same teams or in band, or anyway, our kids knew each other. And so, but I'm so blessed to call this person my friend now, but we can go round and round on issues related to healthcare, especially healthcare policy. And so this is something that Dr. Mary Tipton, I'll introduce her in a bit, but she has been called a unicorn for a number of reasons. Because she is really very engaged in sort of the front side and back side of healthcare. So as the provider, but she also owns a clinic and is a partner in a small clinic in my community, a clinic that I've been going to for years. My family's been going to for years, and but she's come to be very aware of government policy, government regulations that really kind of get in the way. And I'm going to steal her thunder just a minute, but I love when she says, we don't want government between the provider and the patient. Let's keep government out of that exam room. And so I'll let her elaborate on this, but we're going to talk about a lot of great things tonight. We're going to talk about COVID. We're going to talk about challenges to the healthcare system, both access and quality and cost, and that regulatory environment. So these are big issues and things that I want to tackle in Congress, things that I've been looking at the state level and trying to work on too. And Mary's my go-to, Dr. Mary Tipton. Find her on Twitter. What's your Twitter handle?
MD Tipton, MD.
MD Tipton, MD, and follow her, because if you want to know the real stuff that are impediments to good access and reasonable costs in healthcare, you're going to find it with her. So anyway, I want to welcome Dr. Mary Tipton.
Thank you.
To it. So
thanks for having me.
Tell us more that I didn't include. So.
Well, like she said, I'm an owner of Copperview Medical Center. It's in South Jordan. We do have 17 different providers, so I do differ on one point. She said we're a small clinic, but I think we're kind of big, but it's all relative. We're small compared to a lot of big fish in the sea, that's for sure.
It's one story. One floor.
Yeah. But
and
we've been there.
There's another hospital down the street that they call the Death Star. And I don't know if that's because of the size or because of what happens in it, but I don't know that a hospital really
Definitely they have a lot of weight to pull around compared to smaller practices and private practices like us. And we are unfortunately in the minority. When I started practicing here in 2006, we were one of many private practices for pediatrics, for internal medicine, and now we are so rare, and that is really sad. There used to be probably at least 10 internal medicine practices where in South and West Jordan, and now there's like us and no one else. And I think that just really speaks to the fact that private practice and independent physicians are being pushed totally out of the market by the onslaught of oppressive legislation and government requirements and just the really excessive government intrusion, I think, into our relationships with the patient. And it's wrong.
Well, So the most pressing question I've been waiting all day to ask you
Yes.
is this is the Kim for Utah campaign drink of choice. Is it okay for me to drink this? I'm just kidding. It only has 300 milligrams of caffeine.
Oh, okay.
So,
That should get you at least 4 hours.
give me 4 hours. So
Not too different than the espresso shots, I suppose, that other people utilize for that purpose.
yeah,
But
this is rain, and
that's
this
funny.
is-
I've never tried any of
It
those.
is amazing.
That's
to
what I
keep
warn
us
my
going.
teenage patients about.
Oh, to not drink. Okay, teenagers in the back, yeah, don't drink it, says Mom and Dr. Mary. Okay, so the neighborhood clinic or the community clinic, and I don't even know that you want to call it that because it's not the same as what we think of as community clinics, but you're in my community.
Yeah.
And
No, I think it is.
I first started going there because I had a neighbor who was a doctor who practiced there. You're close. So I go there and I feel like you know me, and I have relationships, that doctor-patient relationship. There's a continuum of care, but for that, that experience with a primary care physician who knows me is valuable, knows my family.
I think that's what it all comes down to. I mean, everything in this world comes down to family and relationships and just trusting and knowing someone. I mean, anyone in business can tell you that if you have a job for someone or you have something you need, you're going to go to someone you know or you trust. And a primary care physician can be that person. And it's a unique and just blessing in my life, I think, to have those relationships with these type of people. And it's a special thing. So yes, that's why people often do come to see us and stay seeing us, because they say, well, Dr. Tipton has my best interests in mind, or Dr. Tipton knows what I went through before this illness happened, or Dr. Tipton knows, what my family life is like and why this challenge is hard for me. So I value that, but it doesn't pay the bills. And certainly I think things that get in the way of that relationship, like cumbersome electronic medical records or really expensive pharmaceuticals that eat up the whole visit time talking about, or just the onerous amounts of documentation that we have to do after the visit, just make all of that good part less and less shiny.
Okay, so I've got to think, when you talk about regulation, you have two things that have happened in the last couple years. So do you want to take COVID first, or do you want to take the ACA first?
Oh, heavens.
Which is...
I think they are somewhat interrelated, because the main problems in our healthcare system have been absolutely unmasked by coronavirus, I feel like. So it's a bit of an opportunity and for us healthcare reformers who can try to find a way to say, look, things were already bad, but then we had this coronavirus issue that just took all sorts of problems to the forefront. So we could talk about both, because intertwined. Do we have a question?
Okay, so we have a question. Is it a good time?
Can you provide the COVID-19 survival percentage?
Okay, so maybe let's go to COVID. What have you seen personally? And then let's
Sure.
see if we can answer.
I know that the mortality rate in Utah is 1%. So I guess that would mean that the survival percentage is 99%. So if you got coronavirus in Utah, you would have a 99% chance of survival. And if you are below the age of 65, you would have a much, much even better chance of survival. One of the most important things that I feel like it hasn't been mentioned as much, and that I was able to glean just from the coronavirusutah.gov website, where they are now publishing percentages and mortality data with more information, because they have a number of patients. Like when there was only 10 dying, it just doesn't make a lot of sense to put in, statistics. But now that there's 88, I think it is today, they can kind of say, look, this is what we're learning from this. So 95% of people that died, and again, it's just 88 out of the tens of thousands that have been tested, 95% were considered high-risk individuals. 95%. So that means they were over 65 and or additional underlying health situations. So this is definitely not a disease that's killing young and healthy people. And the median age of those who are dying is 74. So that's the median. That means, half of them of the 88 are above age 74, and only half are below. And I can tell you that very few are below 40. Like none, almost, in Utah, I think. So coronavirus for us has been very interesting, but I think it's been an illustration of how well our private practice can pivot. So we found out about coronavirus like everyone else. You know, it's probably not a big deal. It's probably going to be okay. Wait, is this a problem? This is a problem. Middle of March, we're like, we have a problem. And so we were able within 1 week to develop telemedicine, to restructure all of our protocols, to buy a tent and get it up and running and do coronavirus testing, to completely change the way we triage patients, see patients, and document and bill patients. And for a private practice, again, you know, we have 95,000 patients on our roll, so it's not that small, but, and we're open 7 days a week. We were able to do all that because we don't have people, you know, above us who are owned by a bigger corporation who can say, you can't do that. So I'm pretty proud of what we were able to do to respond to the situation. And it was drastic, what we had to do, as was the national and local government responses, but I think it was justified for what we knew at the time.
So, so you were kind of one of my go-tos on this early on. So before we came on the live, I said, you know, let's of course we need to talk about COVID.
Yeah.
And you said, well, I'm not the most expert, but yeah, I know, yeah, you're a practicing physician. But my first thought is, well, who is, you know, really, who is the expert right now?
Gosh. Yeah.
And because
We're all learning.
yeah, we're all learning, but you also, you know, as you indicated, coronavirus has exposed and highlighted and exacerbated weaknesses in systems. But I think for me, the primary one is, what do you trust with data, and what
Yep.
and who do you trust? And we really did act very quickly. We quickly went into a state of fear and started reacting. But you also, you had people, family, friends in England who were practicing and really seeing some devastating things. People in New York.
San Francisco, in the
Francisco.
epicenter on the West Coast.
Okay, so you're seeing this, and we still don't really know why are these hot spots
So much worse.
worse, and we don't know what it means, and the data's lacking. So we really
Yeah.
rushed to taking some pretty extreme measures, and we'll probably wonder forever if we went too far, didn't go too far. What we do know is we have not seen it that badly here.
Yes.
But who do you rely on?
Any analysis is subject to the prevention paradox. What I mean by that is when you do excessive amounts of prevention or shutdown, you'll never know.
Right.
If you did that and it worked out and that was amazing and you're so glad you did and it would have been bad, or it was all a waste. And I don't know that anyone will ever have a complete answer to that question, sadly. But I think you're right. I have a very good friend who does internal medicine in San Francisco, and she was just part of a mess, as it was in most of these places where it just hit them at a very high rate. I mean, she had like 300 positives just in her small clinic, and she told me about what they were going through and how devastating it was, and I thought, well, I can't really think of many good reasons why it would be different right here in Salt Lake City than San Francisco, basically at Stanford University, like, you know, big city, not just like, I don't know, places we could say, it's another country, it's New York, it's
Right.
different than us, they live different. So I think we did our state and our country, I think, responded according to the information that they were given. Now, some of it we turned out to be incorrect, some of it was perhaps overblown, but the important thing then after that is to rein it in, you know, to say, well, let's pause, let's
Breathe.
let's do what we have to do, because we don't want to be in that position where we say we should have done this, we should have done that, and we didn't, and people died. But if you don't also take the next step and say, but I'm going to take this time to prepare, to learn what is really going on, to analyze the data, I really feel like Utah has done a pretty good job of this. I have been glad over and over that I live in this state and not
Yes.
others.
Yes.
I do feel like there's a collaboration between Dr. Dunn, the epidemiologist, and then the business community and the government, and that there's no one person running the show, because, like, for example, if we wanted 100% safety and never anyone to die, we would still be shut down.
Right,
And if it was only doctors or healthcare workers making the decision, that's never a good idea. You have to have a balance, because there's so much collateral damage from a shutdown. So I think it's wise that we are saying now in Utah and locally especially, like, this is a risk. This is a problem. But there are many problems by reacting in an extreme way, where we squash commerce, where we strangle the economy, where we keep people in abusive situations at home, where we take kids out of school. There are real problems with that. And I'm telling you, that is what I have done my whole last couple months, is deal with those problems. Mm-hmm. We have hardly seen coronavirus at our clinic. We have been testing for it. We have been looking for it. We have done hundreds of tests. We have had only 3 positives, and they have been hardly sick at all. What I have been dealing with 24/7, and all of my partners, is the depression, the mental health problems, the children at home not even getting the therapies they need. So I know more than anyone, both sides, honestly, because I see these people suffering, So I feel like we're doing the right thing right now to open up more and to monitor. We have tools now that we did not have before, that we can just test, quarantine, contact trace, squash these little outbreaks. So we have tools going forward, and we're going to be fine.
So some of the things, and I just got to tell you, I don't know anybody who works as hard as you or keeps the crazy hours you do, except that I'm up at the same time you are frequently.
That's why we understand each other.
But I know I can text Dr. Mary after midnight, and she's still working through this problem. And some of the things that have stuck in my mind as you were responding, and as I was reaching out to you to see what you were experiencing. Masks. That was one of your first early concerns, was the PPE and not being able to get the PPE.
Right.
And you and I have been talking about for a year. I mean, one of my soapbox issues is the China RX situation.
Yep.
Read the book, China RX. And that China has positioned itself as the world's manufacturer of the primary active ingredient in all the world's drugs. Mm-hmm. And so when I've been harping on that, I don't know that a lot of people cared, but now, holy cow, all of a sudden, we understand what it means for one country, and one country who's willing to hide facts from us, lie to us, do not have our citizens' interests in mind, to be totally dependent on that kind of country.
For our
but then we find out that they manufacture all the PPE too.
Yeah.
And so I remember as a legislator...
Don't worry, they're going to come up with a vaccine. I'm sure we can trust that too.
Oh, wow. So, and there are horrible stories about vaccines and drugs that come out of China. So I remember early on the legislature got together and on sort of a conference call talking about what's the status of PPE. Well, we're waiting on shipments from China.
Yep.
So now people care about this, but you and I have been talking about it for a year.
And a lot of people that I work with in Washington and around the country that are working on healthcare reform. Definitely our healthcare supply chains are vulnerable, and they'll never more vulnerable than right now, like during a pandemic or any sort of bioterrorism type of act that could occur, or a novel infection that requires specific antibiotics. If we are dependent on another nation or multiple nations that are also experiencing the same problem and withholding their supply from the supply chain, we are very vulnerable to getting bad supply, no supply, all those sorts of problems. So that's one of the things that's been illustrated. I think the Affordable Care Act and the policies of our administrations previously have been to consolidate, and move products and markets and manufacturing overseas. And not just, I think, for the drugs, like you said, but the ingredients that go in the drugs. Mm-hmm. So, all it takes is like one link in a whole system of making something. If you don't have that one piece or that one thing, you could maybe not get to the final product.
Right.
So thankfully, I think the America First platform or whatever that Trump ran on, many of the things in his campaign have really been like, oh, he was right on that.
He was right.
And this is one of those.
This was definitely
And
one
so
of
that'll
those.
be a good thing that comes out of it, is if we can shift some of our production of pharmaceuticals and research and stuff.
You know, we can. You know, we can. So
Yeah.
we're America. We innovate. We can create we can bring the manufacturing of these drugs back.
I agree.
And there's a lot of discussion about that now, and we can do it at very similar or even better price points than what we've come to depend on China. And China, you know, for years undercut the markets so that almost all the countries in the world then they outsource to China. So
But-
now we're
And
looking
definitely
different.
government policies underwrote their ability to do that, I should say. So, for example, the oligopolies that control the healthcare supply chains in this country, there's big pharmacy benefit managers that control 95% of prescriptions in this country, 95%. So those are big buyers. That's what we call like an oligopoly or a monopoly, but it's just like three, but as a whole, they form a monopoly essentially.
That
And
was
so-
the most awesome segue right there, the PBMs.
So those.
So let's back up on that.
If you
and
have that
let's-
much consolidation in the market, is what I'm saying, then you can force people out very easily. You can make secret contracts or not so secret contracts that just are exclusionary, and that's how we got into this situation in a lot of respects, because that same type of market structure exists not just for pharmaceuticals but for hospital supplies and gowns and masks
And
and
that's
that
what we
sort
saw.
of thing. Yeah, so any kind of like American manufacturer that just wanted to like make a drug could not get in the market because they have to pay to play. They have to pay a lot of money to these middlemen to play. And if they can't pay to play and they just want to make their one product or their, generic drug that is not a big moneymaker, they just literally can't do it. And so they're out of business, and then you have, they buy from wherever else they buy from.
Okay, so let's
So-
back up there and
Okay.
let's give like the basics for people. Explain what that, because you said real quickly PBMs, pharmaceutical benefits managers.
Yeah.
Now you have been on a soapbox for as long as I've known you.
Couple years now.
About wanting to reform the PBM. So what is it, and why did they come to be a government sanctioned and a government even to some degree created entity that is driving up healthcare costs and pharmaceutical costs? And so in this legislative session, we dealt with the cost of insulin. So insulin, I think, is a drug that everybody knows somebody that's on insulin. So this is one that yes, our producer volunteer Dorn Barton is insulin dependent, and so there is we had a couple of bills dealing with this. What I now know about PBMs, I think some people described our effort to cap cost on insulin or insulin co-pays. All that does is squeeze the balloon, and somebody else, now my father's heart medication is just going to go up. And so to cap costs on some things, if we're not fixing the structural problems, the broken things that are within that distribution chain, we're not really fixing anything. We're still, we're letting PBMs get away with what they're doing. So tell us what that is and how they came to really be a good part of the blame for our escalating costs of pharmaceuticals.
Yeah. Tough to squeeze into a little bit of time, but I will just at least first characterize them as middlemen. Pharmacy benefit managers do not manufacture, create, research, design, test, package, sell the drugs. They don't do anything except create contracts that, by the way, are secret and only readable by certain members of the government due to a safe harbor law that they have, where they can collect fees and kickbacks and all sorts of things without disclosing them. Yes.
They're allowed to take kickbacks.
Legalized. Yeah, that's why we call it a safe harbor, because these pharmacy benefit managers can collect kickbacks without reporting them, so they're legalized kickbacks.
Safe harbor sounds so nice.
Yeah,
this is a nice
it's an unsafe
thing.
safe harbor.
It's within that safe harbor is an allowance for kickbacks.
Yes, exactly. And only Congress. That's why we need you to go to Congress. Only Congress can repeal that law. No executive order, even though Trump is very aware of this sort of thing and wants to repeal it or change it, he can't do it. Actually, it does have to be Congress. So the pharmacy benefit managers were created as a middleman that they said they would save costs. So they're going to buy and manage the pharmacy benefit between the patients and the healthcare insurance company, something. So they said, don't worry, Medicaid. Even Medicaid and Medicare, by the way, are almost exclusively controlled by these oligopolies. So we don't have government healthcare. We have a huge industrial healthcare complex that is big business. They under the guise of Medicaid and Medicare. So these pharmacy benefit managers really said that they're going to use their power, their buying power, to decrease costs and to negotiate contracts. They're really bad negotiators, by the way, because they have an inherent conflict of interest. Their fees and their income and their money is all directly proportional to the cost of the pharmaceutical. There's no incentive in the system for these middlemen to decrease costs at all, because all of their fees is a percentage, a kickback. So the way that the whole system is structured is unfortunately just set up so that they have a perverse incentive to keep costs high and to hide the real cost, and then to distribute it amongst all of their affiliated businesses. And there's a lot of affiliated businesses now. These middlemen, let's just call Express Scripts, CVS Caremark, and Optum. They are closely affiliated with health insurance companies. They're basically owned now by health insurance companies, and that money that is billions and billions of dollars, estimated $200 billion a year, it just freely flows between these companies without any transparency. And so all of that is money being sucked up. It is not helping patients. I can tell you that. And it is not going to doctors. We write the prescriptions. We can't even take a pen or a Post-it note from a drug rep. There's no drug reps around anymore, but lately, just because of coronavirus. But we can't even take that without reporting, income. And yet we have these billion-dollar industries, interestingly, that can just collect money off the backs of all of us at the pharmacy counter without us really even knowing and without having to report that. Okay, so the lack of transparency and the setup of the perverse incentives and the kickbacks and the middlemen are just a way to them to kind of scratch each other's backs and basically give money to Congress and political leaders, I believe, to maintain their status and their income.
Okay, so we like to vilify big pharma. We like to blame a lot of the drug costs on big pharma.
Yeah.
I don't know that people know there's somebody in between.
Yeah, I think they don't. They're kind of silent. I mean, they're maybe like on the bottle, but they don't. Yeah, I agree. I'm a doctor, and I've been a doctor for 20 years, and I did not really even understand what pharmacy benefit managers did or why prescription costs were so high until about 3 years ago.
But the safe harbor rule, we're going to turn a blind eye to the kickbacks, or we're going to allow it, wink, wink. When did that pass in Congress? Do you remember?
1987 is when it was extended to group purchasing organizations. Okay. So they also have these safe harbors and kickbacks. McKesson, that wouldn't send us a single mask. McKesson, that cut off our supply of all of our gloves and hand sanitizer because we are the little people. We had no supplies for coronavirus because our GPO that runs all of our supplies just was like, we're canceling that order. So group purchasing organizations that own and run hospitals, they have a safe harbor as well since 1987. And then in 2003, which not coincidentally is when pharmaceutical prices, by the way, have just done nothing but skyrocket, is when pharmacy benefit managers got their safe harbor by Congress. I think it was 2001 or 2003, but I think it was 2003.
Okay, so if you're watching this, please let us know if you have any questions. This is a great discussion. So ACA, let's jump over to ACA, was
10 years ago. Just had its anniversary.
Woohoo! Cut the cake? Should we celebrate? Happy birthday to ACA. Okay, how has this impacted your clinic and your practice?
So the Affordable Care Act, I believe, has and always will be a gift to the people who benefit from healthcare, the industry, and that is the insurers and the hospitals. There's no comparison to how much lobbying dollars go from these big companies like healthcare companies and insurers and the American Hospital Association to lawmakers. They had a big role in playing in making the ACA, and they did that so that they could keep profits, because more people that have insurance are more people that have claims and more people that they can service. But more insurance does not equal more care. And more insurance does certainly not equal lower costs. Because whenever you have a third-party payer in place and you have flat fees where people just say, well, I mean, you could have a Ford or a Ferrari. And I mean, for you, it's just 100 either way. So what do you want to just go with the Ferrari or?
Yeah.
And I'm thinking, yeah, I mean, why not? So, and that's what we have in all of our expenditures, is a third-party payer system and not a clear connection or price transparency of what things really cost and the cost being affected from or being felt by the consumer. So that has inflated costs. So in my opinion, the Affordable Care Act has made things less affordable, consolidated the market further. So like if anyone has tried to get insurance on the marketplace, they know that there was like 7 providers at the beginning in Utah. I think like 7 or 8 maybe even. And then there was 5 and then 4 and then like 2 now. And that's in a lot of markets. Did you know in the U.S. a lot of markets have a single option? So I mean, people just really do not have that much of an option. There's not competition. So more consolidation increases costs, and it's also just been one of so many onerous burdens, like I said, for private practice. So I mean
So you mentioned the electronic
medical record. That was actually the High Tech Act. But I mean, it's all very much the same people that are making all of these rules that sound really good to bureaucrats in Washington, but are really horrible in person and are not made by doctors and do not really help patients and have a lot of unforeseen consequences. So it's been astounding, really, to see how much more time I have to spend outside of patient rooms doing all of this documentation and running a business. And I think it's sad, and it drives people out of medicine who would otherwise be excellent caregivers or physicians, because and they're out of private practice. And really, in private practice, you have more autonomy and you have your ability to change things that aren't working for you. And there's so many physicians now that are just literally cogs in a wheel. And that, I think, adds to their dissatisfaction as well with their workplace environment. So we have physician burnout as a big problem. So I guess that's a long answer, but there's definitely a lot of problems that Affordable Care Act has caused. In my opinion, it caused more harm than good.
So is the answer to socialize more and go to single payer, a single payer system?
No.
No?
Negatory. Absolutely not.
So what do you think?
Denied.
What are the answers then? What's the answer?
Well, I wish I knew that.
It's simple.
In general,
In
it's
3 seconds.
less government intervention, I think, in the market. People will say, well, we have a free market. We do not have a free market in healthcare. We don't have a free market any more than we have a free education, a free, like teachers can do whatever they want in the classroom, for example. Like there's so many restrictions in a lot of industries in our country. And so I feel that physicians are in general very motivated, very smart people who want to do the best for their patients. And if they were allowed to do that without all the in problems and stuff in between, then we would find a way. We would find a way to take care of our patients. We would provide a safety net for people. We would provide charity care. We would do it at a lower cost. And we would actually potentially have better quality than these quality counters. So I think government just mostly needs to reduce regulation and let us take care of patients.
Do what you do best.
Yeah.
So let's talk about transparency and cost. So just this week, I got a bill, and I was debating on whether I wanted to say what it was for, but I will. I am over 50 now, and I'm supposed to have a test after 50.
Yeah.
So I'll just say, because by way of also encouraging you to get your colonoscopy.
A screening test.
Your screening test.
Colon cancer.
And so I thought I was calling within my provider network, and next thing I know, I get almost a
surprise medical bill?
$6,000 bill. And as we tried to work through our insurance company and the provider, it's outrageous what we would have been charged in system,
Yep.
what our insurance would have covered, and the fact that I went through so many steps of an intake that I wasn't aware, nobody made me aware that, oh yeah, your insurance isn't going to cover this, this is an out-of-network thing. And frequently the patients don't always know how that system works.
Absolutely.
So then I get a surprise bill, and tell me why a procedure will cost one thing if it's in network, but a bazillion times more if it's out of network, doesn't it just cost what it costs? Doesn't a colonoscopy just cost what it costs?
Only in a truly free market.
Only in a truly free market. So why can't we have simple transparency?
Yeah, this is a great question. I second, again, President Trump's push for transparency. I think it is key. I think all of these conflicts of interest, I think these padded pockets, I think these backroom deals will become open. We call it the Sunshine Act when we want to show, shine light on these potentially nefarious transactions, or maybe they're not. But unless we have sunshine showing and transparency, we won't know. We won't know. So if we can just get some transparency where patients could actually compare costs and say, oh, a Ferrari is a lot more than a Ford, and really I don't maybe need all that, and I don't have the money, so I'm going to have to make some compromises and change things around, and maybe I'm fine with a Ford. So unless we have some transparency, I don't see how we can have a free market, number one. And number two, the transparency is absolutely key, and I think will lead to a lot of changes and unlinking of all of these things that are shrouded in darkness, because within darkness you have people trying to capitalize.
That's right. And competition is a big part of keeping costs down and improving innovation. And so where we have so many
in all industries,
so many strings attached to everything. Okay, so we have a question.
I would love to take a question.
Repeat it after I say it, because I'm not Mike. Is there an advantage in using an insurance company mail order prescription service over a pharmacy?
Is there an advantage to using a mail order prescription company over a pharmacy? Okay.
I believe there is very few advantages for patients, and the pharmacy benefit managers that I talked about are almost exclusively these pharmacy mail order companies. So they will do almost anything to push you into believing that it is more convenient and better and cheaper for you to get it through the mail order. So I recently filled a couple prescriptions for my kids at a local pharmacy called Family Plaza that I use in West Jordan. That's an excellent private small pharmacy that is literally barely, and not them in general specifically, but private pharmacies are really struggling due to these pharmacy benefit managers because they're pulling all their patients away. So I fill this prescription for my child, and I get like email after phone call after notice after email saying, didn't you want to? Wouldn't you like to? How about you change it? And I just think it should be like.
How do they know you have that prescription?
Oh, because they own all.
Wait, there's HIPAA.
Nope.
No way, HIPAA. Your doctor gives you a script. You take it to the small pharmacy, independent pharmacy, but this third-party big group.
Because the claim goes through their clearinghouse. So they are the pharmacy benefit managers. So they
control the pipeline.
The pharmacy, and they own the claims. Wow. And they own, so they are keenly aware when you fill it. So, there's benefits like coming to your house. That's a benefit. Getting a 3-month supply, that can be a benefit, for sure. But I just think it should come down to what works for the patient and the physician. Like, there are times when you're starting a new medication and you do not want a 90-day supply. You just want a 30-day supply. There are times when you cannot wait 8 days for the mail to come and you just want your prescription and you want to go to the local pharmacy. So, I think people should be able to choose. And that local pharmacist, again, relationship, knows you and says, this is just like that antibiotic that you took last year that you had a reaction to, and I have this reaction documented, like, are you sure you want to take it? Like, a good pharmacist can be worth their weight in gold, when they know the patient and can help them. And you definitely do not get that with a mail order pharmacy. So everything has its pros and cons. It's not that they're evil and bad. I think it's just that people shouldn't be railroaded into doing it, but they really are. My patients are sometimes forced to use mail order after they fill it one time at a local pharmacy. That's a tactic that they use. They're often, like I said, harassed if they do it. And then, of course, they're offered the no copay. But nothing is ever really free. Nothing costs nothing. I tell my kids all the time, nothing costs nothing. So if you are having a free prescription at a mail order pharmacy, there is some kickback, I'm going to say, that they're getting for that somewhere else. Like you said, it's that balloon like coming out somewhere else, and they're like, well, we'll capture that on the other end. Well, and believe me, they do.
And sometimes the other end where it gets captured is me as an employer.
A premium.
Yeah, that I'm paying.
love to jack
I'm
up.
trying to
Yep.
offset the premium. I'm paying part of the premium
Yep.
of for my employees as a benefit, as an incentive
Oh,
to make my employees happy.
Forgot to mention, premiums have gone up, up, up with affordable health care and deductibles as well. So
Right.
with the Affordable Care Act. Yeah.
We've seen that, and we've seen that.
But yes.
So someone is paying somewhere, and you
Yeah,
know what that
always.
means is I have less ability to pay you more in wages because I'm having to compensate so much on the premium side.
Again, I am an employer, and I feel that
You do that too.
keenly. I mean, the expenses that we have for private insurance are unreal. You know, like every other employer probably, and we don't have a huge market share. So I mean, we are paying $20,000+ a year for these plans that aren't that great, that have relatively high deductibles.
You're
and
seeing
it's
less
painful.
benefit, higher premiums,
Yeah.
higher deductibles, and yeah, you might not even see all the costs of this because it might be borne by the employer. And I know for me, I want my employees to have the less of a hit possible. I want to try to keep their deductibles the same year to year, their co-pays the same year to year, but you know, things have to give, and there are just no controls, it seems, on any of this stuff. So we do. I need to throw out props to Representative Paul Ray, who has been a real champion of PBM reform at the state level. He's also been working with members of Congress and the executive branch to try to bring about some of these reforms. And so this has absolutely been on my list as we've talked about it over the last year, especially if when I go to Congress, that this is something I want to work on. Our president is keenly aware. And so he did try to tackle it last year, but the CBO came out and said, wait, this might be too much too fast, so let's really, look at this a little bit more. But so you have been involved directly with Congress, with Representative Kathy McMorris, and what are you doing in association with other physicians across the country?
Thanks for asking. Yeah, I'm part of a multitude of groups that a lot of us started on Facebook, then have had many in-person meetings. One of the groups is called Free to Care. It's a coalition of many different healthcare organizations, also patients, also AMAC. That's the American Association for Mature Citizens, I think. So basically like a more reasonable, less sold out version of AARP. AARP is basically owned, by the way, by United Healthcare and has every incentive to cash in on all of these policies that we talked about.
AARP.
Yeah, they utilize that, believe me. I'm sure that's part of their marketing. They're like, we got that going for us. So Free to Care is, like I said, freetocare.org. Even patients can join or find out what kind of things we're doing. Today, this very day, I was supposed to be at the national conference in D.C. at the Library of Congress, attending that conference.
And I was going with you, so I had that invitation to go. Or no, that was a
different one.
Different
I know there's
conference,
like 2 trips to D.C. this month that got canceled, so I'm a little bummed. But we're going to try to reschedule that for September. But essentially, what we're trying to do, another group is called Practicing Physicians of Organization or Practicing Physicians of America (PPA). It's just as I mentioned, like so different to be in private practice and to really feel like you can advocate for your patients, but we need a collective voice. I mean, we don't have a lot of money to lobby. I have no budget with which to lobby. I have 4 children.
But the PBMs do.
They have literally
Big Pharma
unlimited.
does.
Yeah, so it's David versus Goliath. It truly is. So we just feel like we are the most unconflicted, potentially, people that could talk to lawmakers. We are the people who could say, we want to make things better because we really care, not because I'm getting money from this. I don't get a penny based on which prescription I write, or 0 prescriptions if I write, Truly, I'm unconflicted, and so are the people that I'm working with. And I think that's a beautiful thing to see. We just really want to try to shine the light a little bit on some of these things because the American public deserves to know too. And that's what really gets us is our patients are suffering because of these policies that increase costs, decrease access, and the American public is being fed really a line of hooey. I'll just say
Watch
about
language, watch language.
Okay, so you have to tell us again your Twitter.
about socialized medicine. That's what I was going to say, because
Yeah.
Medicare for all would be a choice for none. My Twitter handle is MD Tipton MD.
MD Tipton.
That's 'cause Mary-
MD.
yep.
Mary.
Delilah, medical doctor. So that's a little play on words there. And then, yeah, that's what I was going to say.
So seriously, I check in on Dr. Mary's Twitter frequently because you are going to get the real scoop. You're also going to get a conservative perspective, if I may say, a conservative perspective of healthcare reform. That so much of our healthcare reform has centered on more socialization, the moving toward single payer system, and yet, as you've said today, as I believe, that our challenges within our healthcare system are much better affected and improved through free market infusion, not less. And things like transparency, things like the right to shop, which I've been a supporter of in our Utah legislature. I've also supported efforts for PBM reform and transparency and costs. And those are all based far more on free market principles, sunshine, transparency,
Patient
follow
choice.
the money, patient choice.
Yeah, patients should be able to choose their physician. They should be able to choose really their hospital. They should, and they cannot in our market. You probably know as a consumer, everything is dictated, just like your procedure you had with the high
get
bill.
a colonoscopy
At the wrong
out
place.
of market clinic. Because you know
Yeah.
what I thought? You know, this is the first thing I thought about that.
It's a made up
I
price.
thought, I don't know where we're getting $5,000 from. Yeah, I mean, honestly, I don't
Yeah.
know where we're going to get $5,000 from. That wasn't budgeted somewhere. But I think of how many people even more would struggle with
They
that.
go into debt
And will that cost deter a patient from getting a screening test that can save their lives?
They
And
absolutely
really,
will.
that's what it comes down to. What we've seen in the regulation with COVID and just the response to COVID, one of your early concerns was if patients might not get their regular treatments, whether it's cancer treatments or whether it is kind of chronic disease treatment, that some of these procedures and some of these tests are being put on the back burner.
And adverse
or-
outcomes. Yeah, it's
and
happened. It's
so
already.
what are we seeing?
Yeah, the data's starting to come out. So everything has consequences. Every choice should be made with a lot of thought. And I think that's something that you will be able to do in Congress. So that's one reason I support you. I feel like you've asked really insightful questions about some of the issues that we've talked about and tried to look at both sides. And that's going to be the key. I mean, nobody knows everything. If they say they do, they're liars, they're wrong, or somehow confused, because these are complex issues for sure, and there's different sides to every story. So if we can just keep an open mind and be kind to other people and just remember like what we're here for and that we're trying to help make Utah and healthcare better, then I think we'll succeed.
That's great. And we can end there. That was just wonderful. But I have one more topic I want to just touch on, and it really is its own Pandora's box. But before COVID happened, the big healthcare issue we were all talking about, and I think really two, we've been talking about mental health, but really closely related to that has been our opioid crisis.
Yeah.
And really, I serve on the Attorney General's opioid task force.
Oh, great.
I'm experiencing that under the roof of my own house with a family member. It's really just we've seen years and years of
tragic.
struggle, but that's what we were all kind of coming together and talking about. And President Trump was also leading an agenda for opioid abuse and addiction, and COVID kind of swallowed it up. But in some ways, there's also been concern that people with mental health challenges during COVID will, frequently turn to self-medication, things like that. But what would you recommend in this?
I think what you pointed out is excellent. I mean, I've been telling people for a while the pandemic that is coming now is mental health, and probably with that is substance abuse. They're definitely intertwined. As a primary care physician, I'm seeing that. As a mom and with teenagers, I'm seeing that with their mental health suffering. So I think everything deserves its attention, but we've got to be able to find ways to live this new normal and be able to address these other epidemics and pandemics that are coming and not make them worse, by an overzealous or irrational policies in responding to coronavirus. For example, mental health can be worse in isolation, avoiding care, or not having access to care because of lockdowns. So it's just going to require a real someone leading our state and also our country that can look at all the different issues, and how they work together, because the consequences for bad choices on all of these topics is heavy, and I don't want to see it happen.
No simple answers here. Well, this has been fun. So I just love following Dr. Mary, and again, go to her Twitter, and you'll be well informed on some. She'll make you think. And she'll definitely make you aware of a lot of things that you may not be aware of. And so grateful to call you my friend and a great resource. And so thank you for being with us tonight. And again, I'm Kim Coleman, and I'm a candidate for Congress in Utah's 4th Congressional District. And I find good, reliable people to go to when it comes to issues that I'm not an expert on. I'm not a doctor, but boy, I've got great people that I can go to. I've surrounded myself with great policy advisors and just people who can help inform me on what's going on the ground, in the trenches, and so I'm grateful for you that you've been that for me. And so again, I am asking for your support in my congressional race. We're just about 2.5 weeks away from ballots in our primary election. So please, if you like what you've heard tonight, I am looking for your support. Would love your vote in this upcoming primary. Go to kimforutah.com. Find me right here in social media. We're here about every night, and also trying to interact with you all kinds of ways, since we can't be on your doorstep, but I'm hoping to be on your doorstep soon. Can I start looking forward to being on a doorstep soon?
It seems. Numbers are looking good. We're in yellow already. Got to give it 2 weeks in yellow, and then we'll probably see.
Because I'm ready to callous my knuckles and start knocking some doors and talking to people and listening to people more than anything. So anyway, thank you. I hope you're staying well and enjoying sunshine that we're having and all of this. So we'll be here tomorrow night, I think, again. We're going to be here tomorrow night. Who do we have tomorrow night again?
Someone amazing.
Joe Cohn from the Foundation for Individual Rights and Education, a national leader in advocacy for campus free speech and due process rights. That is going to be exciting too. We've just got a great week to be with you as well. And what?
Lee Perry tomorrow.
Oh, it's Lee Perry. Okay, Lee Perry. Representative Lee Perry is tomorrow night. Joe Cohn is after him. Okay, so yeah, it's a great week. So. Anyway, hope you're doing well, and thanks again for being here tonight. And thank you, Doran and team, Devin, for helping produce our ability to come to you in this COVID pandemic. But have a great night. See you tomorrow.